So hello everybody, once again, my name is Kyle Dealman. I'm the project coordinator here at the Registered Nurses Association of Alberta, Ontario. And it is my pleasure to welcome you to this interactive webinar that focuses on the effects of cannabis use during adolescence. This series is one of many resources made available by the Ontario Ministry of Health and Long-Term Care and is in collaboration with the Registered Nurses Association of Ontario and the Opioid Resource Hub at CAMH. A few quick housekeeping notes before we get to today's presentation. In the chat box, participants can type in a question or comment during the presentation. However, we will have about 10 or 15 minutes towards the end of the presentation to address these. If we're unable to get to all of the questions in the allotted time that we have, our presenter has agreed to respond to them in writing, and we will get in touch with you via email afterwards. Just for everyone's information, we will be archiving this for future viewing, and we are going to be recording. Just to get a better understanding of how many people are going to be joining us today, I am going to be administering a couple of polls very, very shortly. And if you just take a quick moment to respond, that would be greatly appreciated. So I am going to be opening up the first poll. And we're just curious how many people are viewing the webinar with you today. And we have a couple of options. Just yourself, 2, 3 to 5, or 6 or more. And once again, just if you could please take a moment to submit. And just about 15 seconds left to submit your response if you have not already. Great, thanks so much everybody. So it looks like we have predominantly just watching by yourself, a few groups. That's great, fantastic. And the next question we have, and if you just take a moment to respond to the poll, so what region do you work in or does your organization serve? And just about 15 seconds left to submit your responses. Great, thanks so much for that. And the last poll, we have in which sector do you work? And just one more time, please submit your responses. And about 10 seconds left to submit. Great, thanks so much everybody for taking that time to submit your responses. That information helps us out greatly. So now let me turn to Tamar Meyer. She's a supervisor for the Opioid Resource Hub at CAMH, and she's going to introduce today's webinar presenters.
Thank you so much, Kyle. We are very delighted today to have an excellent presentation from Sheena Garrity and Dr. Sharon Cerrone. So on behalf of the Registered Nurses Association of Ontario and the Provincial System Support Program, we're very excited to be presenting today's webinar, The Effects of Cannabis Use During Adolescence. Sheena Garrity is a knowledge broker at the Canadian Centre on Substance Abuse, which has a legislative mandate to provide national leadership and evidence-informed analysis and advice to mobilize collaborative efforts to reduce alcohol and other drug-related harms. In this role, Sheena is responsible for synthesizing evidence and developing key partnerships with various stakeholders to mobilize knowledge. Sheena earned a PhD in neuroscience from Carleton University with a focus on stress, coping, and well-being. Dr. Sharon Cerrone is a family physician with a fellowship training in addiction medicine. Clinically, she's an addictions consultant to the child and adolescent mental health team at St. Joseph's Health Centre here in Toronto. And she also has a private practice in addictions medicine and psychotherapy. Sharon is involved in addictions medicine education provincially as a mentor and a member of the steering committee of the Medical Mentoring in Addictions and Pain, which is a collaborative network at the Ontario College of Family Physicians of Canada. So welcome both Sheena and Dr. Cerrone. You can see their full bios in the WebShare pod. And actually, before I turn it over to Sheena, I'd like to just present a couple of slides. If you wouldn't mind just advancing the first couple of slides, Kyle, just to provide a little bit of context before turning it over to Sheena. So we've done the introductions. We're going to highlight some results from the OSTIS, and then we're going to turn it over to Sheena and then Dr. Cerrone. So as some of you are aware, the Centre for Addiction and Mental Health has one of Canada's longest-running student surveys around mental health and addictions. This is called the Ontario Student Drug Use and Health Survey. And this survey annually reports on students' mental health and well-being, reporting on indicators such as alcohol, various drug use, as well as mental health and mental illness. So from the 2013 OSTIS, you can see here that the percentage reporting cannabis use at least once in the past year is about 23% of overall students. You can see that there is not much of a difference between males and females, with 25% of males reporting at least once use in the past year, and 20% of females. There's a significant increase in grade, starting only at 1.7, but increasing significantly to grade 12, with 39.2% of students reporting cannabis use. And there's no regional variations between Toronto, North, West, and East. If you can go to the next slide. When we look at frequency of drug use amongst past year users, you can see that cannabis is the most frequently reported drug. So over 47% of identified self-reported students who've reported using drug use, 47% identify cannabis being used 10 times or more. And this is very important information in terms of thinking about not just the prevalence of use, but the frequency of use. You can go to the next slide, Kyle. Perhaps one of the most consistent and robust factors associated with future substance problems is early initiation of use. So research has shown that those who begin using substances at an early age, which is typically defined at age 13 or 14, are more likely to develop substance use disorders and problems later on in life. So you can see here that 2% of seventh graders use cannabis for the first time before the end of grade 7, compared with 8% in 2003 and 9% in 1981. So this is a really good shift. This is a really good shift. Students are taking up and reporting first-time cannabis use at a very at a later age. So this is a really good population indicator. And finally, if we look at long-term trends, so this is only reporting on grades 7, 9, and 11. The 2013 cannabis prevalence is significantly lower in historical peak years of the 1970s, as you can see on the graph, and also in 1999 or early 2000s. But this, you can see all these dips and valleys. This still is a concern. And I think what Sheena will talk to is why we need to continue to think about cannabis use amongst youth. So, Heather, would you mind actually putting some information about the OSTIS and how to access it? You can access it online, and it's a very useful report in terms of making evidence-informed decisions, policies, and programs. So at this point, I'll turn it over to Sheena.
Great. Thank you very much, Tamar, and good morning, everyone. I'm very happy to be here to present. And I'll tell you a little bit about some of the work that we do here at CCSA. To very quickly summarize, we release a report about every 2 years in a series called Substance Abuse in Canada. And these reports address key substance abuse issues that are emerging and really deserving of some immediate attention. And they are targeted at policymakers, individuals responsible for program development, researchers, educators, health professionals, and they really speak to what are the changes that we can make in policy and in practice. The reports typically have a neuroscientific point of view, and previous issues have focused on things such as youth, concurrent disorders, drug use during pregnancy, and the implications this can have for both mother and child. And most recently, our report looked at the risk factors that can be identified in early childhood that could indicate a risk for developing substance use disorders later in life. Our reports are developed in conjunction with our Scientific Advisory Council, and this is a group of individuals who are really at the top of their field in neuroscience, mental health, and addiction, and so they come together and we really speak about where there are need for new and up-to-date information, and how can we make a difference in providing this information to the public. And this slide just provides you with an overview of those individuals who do participate on this council. Before we began this report, we used an integrated knowledge translation methodology throughout the process. So we gathered together a group of stakeholders at the very outset, and we took the time to hear what exactly is it that you need to know about youth and cannabis use, what are the questions that you want answered in this report, and where should we focus and where should we stay away from. And the main message that we heard in these consultations is that people are not well able to discern what is true and what's not true when it comes to using marijuana. And so that was really what we focused on within the report. And in today's presentation, I will get into dispelling some of the myths that youth hold. But we really rely on our partners to help spread the message and to implement the findings of our report. So I'll be glad to hear anyone's thoughts that you have about resources that may be necessary to help get this information out, or the ways that you may be able to work with youth in your practice to communicate this information. So as mentioned, our report focuses on the effects of cannabis use during adolescence. And a few things to define before we start. When we're speaking about cannabis use within this report, we're talking about regular use, which is defined as daily or almost daily. And the reason is that this is where we see the most harm. And so this is a caveat that needs to be remembered when we discuss all of the findings. And then also when we speak about youth or adolescents, we're actually speaking of a range of 10 to 24 years. And so the goal of these reports was to provide clarity around misperceptions and conflicting results that are often reported, and also to speak about the impact cannabis has when this brain is still under development, as it is from 10 to 24 years. We know that adolescence is a time when there are significant social and psychological as well as physiological changes that are happening to a youth's body and their brain, and it's also a time when we see the peak emergence of mental health problems and the start of substance use. So that's what really helps us focus on this key time period. So to start, we just wanted to look at why youth may choose to use cannabis in the first place. And research has shown that there can be a variety of issues that youth cite as their motivation. Some youth use it because they think it's exciting. They think that it enhances their experiences, or that it may help them be more social and enjoy themselves when they're at a party. Other youth use it because they need a coping mechanism, and so they say that it helps them forget about their problems. They also say that it expands their mind. It helps them to understand things in a different way. And they also speak to the importance of their peers and what others are doing, and they say that they want to use cannabis so that they don't feel left out from other people who are using the substance. And finally, most recently, there has been another component that's been added, which is that they simply do it out of habit, and they do it because they're bored. It's also known that youth may have different expectancies or the experiences that they anticipate they will have after they use cannabis. So some see it as being a positive experience. that it will lead to relaxation and tension reduction. It may facilitate their ability to be social, and it can also enhance some of their perceptions or cognitive abilities. And yet other youth see that there can be negative implications of use, that their thinking or their behavior may be impaired, that overall it could just have an impact on their life, and that there can be certain physical effects and cravings. And so what we see is a good correlation between those who expect cannabis to have positive implications tending to use the substance more, and understandably those who think that it's going to have a negative impact on their life using with much less frequency if they're using it all. And now the reason that understanding why youth use is important is really well displayed in this image right here. And what we see is that there's a direct inverse relationship between the perceptions that individuals have of the risk that can come from using marijuana and how much they tend to use that substance. So as the perceptions of risk go up, the use comes down, and then conversely, as individuals begin to see marijuana as more benign, their perceptions of, their use of the substance does increase. And you can see that these patterns have changed over time over the past years. We looked further into youth perceptions of marijuana in another report that was released by CCSA, which is called What Canadian Youth Think About Cannabis. So we held focus groups all across Canada with individuals who are 14 to 19 years old. And so throughout this presentation, I'm going to be sharing with you some of the myths that youth reported during these focus groups, and then the evidence we found in relation to these myths in our most recent report. So one of the first things that we hear from youth is that everybody is using the drug. And so one of the quotes we heard in our focus group is, it's like every single one of your friends is doing it, and so you know maybe two people who aren't doing it. You're like, well, everybody's doing it, and they're fine. Why wouldn't you do it? I just want to try it. And so as Tamar was commenting on, and some of the data that we've seen is that youth do tend to use cannabis more than any other illicit drug, and that this use really can begin quite early in elementary school. So while we do see that rates of cannabis use are still lower than alcohol use, about 19% report using cannabis with 41% report using alcohol, these rates are higher than cigarette smoking. And we've seen that when we look at older adolescents, individuals in grade 12, almost half of them report that they use cannabis within the past year. And the rates of almost daily use are very high and peaks among those in grade 12, with 5 to 10% of individuals saying they use cannabis almost every day. Another component that we hear from youth is that it's natural, and so it's positively harmless. And we even heard one individual in our focus group saying, for me, I think about my health. I take care of my health because I smoke 2 packs of cigarettes a day. A cigarette gives you cancer, but the weed will cover it up. It's going to clean it up. And in fact, we know a lot of individuals are a little bit confused about medical marijuana and the fact that perhaps it can actually be used to treat illnesses. So I just want to start by providing a background of how cannabis actually does affect a youth's brain. And so the reason that it is able to impact anyone is because we have a system in our brain called the endocannabinoid system that responds to endogenous or internal cannabinoids that we naturally have circulating. Now, during youth, as many people know, brains are undergoing extensive pruning, so connections are being refined, and the efficiency of the brain is being increased. And certainly the prefrontal cortex, the area that's right at the front of the forehead, is the very last area to be developed, and it's of critical importance because it can really be considered the CEO of our brains. It's responsible for very high-level functioning like decision-making, judgment, emotional regulation, goal setting, and things like that. And this natural endocannabinoid system that we all have helps the refinement of the brain and helps the activity in the prefrontal cortex by really regulating the activity and the communication that occurs within the brain. brain that the endocannabinoids are meant to bind to. However, this happens in much higher quantities. So the cannabis actually floods the system and prevents it from working efficiently. And so this can result in a lot of disruptions in the brain, and it can actually alter many of the complex processes that we really need to develop effectively and efficiently at this time. And this is what can lead to some of the changes in brain structure and emotional and cognitive performance. This is also one of the main reasons why the age of onset of cannabis use is so important. And this is one of the main key messages I really want to stress in this position. And it's that when the prefrontal cortex is still developing and individuals taking use, it can really have long-term impacts. And so the later that a youth may choose to wait to use cannabis may indeed be protective for their functioning. Another myth that we often hear from youth is in relation to driving and how, in fact, weed can actually make you a better driver. And they've said things like, if you get drunk and you drive, you'll crash your car and you may kill a baby. However, if you get stoned from using cannabis, all that happens is you forget your keys and you walk home and you may eat a little more. And youth were very consistent in telling us that even if cannabis may impair your driving abilities, it's certainly much safer than if you were to drive after using alcohol. And so the image that I have on the screen now is actually from a series developed by the Ontario Students Against Impaired Driving, which is called Eggs on Weed. And they have a number of animations and a website that's really informative. And so what we're trying to communicate is that the research really does show that cannabis does indeed produce deficits in intentional focus, information processing, motor coordination, reaction time, all of which come together to really make it unsafe to operate a motor vehicle while you're impaired by cannabis. It is indeed associated with a significant increased risk of collisions compared to those who are driving without using any substances. And this risk is even heightened when an individual uses cannabis alongside alcohol. And we know that polysubstance use is something that often occurs. Drivers who use cannabis have been shown to compensate by driving a little bit slower, and this may be why youth seem to think that it's safe. However, they have reduced control when there's complexity that comes at them. So when there's things such as watching a car that's passing you, monitoring that the lights are changing, being aware of a cyclist that may also be on the road, they really struggle, and this can result in more lane leaving, slower reaction times, and an impaired ability to really attend to all these different components that are going on while driving. And data from our National Fatality Database revealed that in the last decade, marijuana was the most common illicit drug present among fatally injured drivers in the 15 to 24 age range. So we know for sure that this is really important and that youth need to know that, in fact, impaired driving is not safe. GCSA has done some work to look at how we can effectively communicate the dangers of impaired driving to youth, and in our review we found that the components of effective prevention programs, and these were a variety of programs that range from things such as exposing youth to the repercussions of impaired driving by taking them to hospitals and having them see the outcomes of the harms that individuals had experienced, engaging in discussions about life skills, coping, how to deal with peer pressure and enhance your self-esteem, as well as having to develop messaging and prevention initiatives for their own peers. And we found that they were most successful when parents, peers, school, and the community were included. So looking at a variety of ways to deliver the message from multiple sources. When the interventions really spoke to thinking critically about choices and having control over the decisions that you make, when the risks were made real, when people saw that, in fact, you can have injury and trauma by driving while impaired with cannabis, while the messaging was created by youth, it was able to speak better to their own peers, the things that they're used to hearing, the language that they like to hear. And finally, that they have to believe that the enforcement is real. So they needed to know that indeed police were having or citing repercussions for individuals that were driving while impaired. And so while we see that these components could be effective in changing people's awareness and their knowledge about the issue, there is no literature as of yet that really speaks to evidence for behavior change. So this is an area where we still need to do a lot of work. Another myth that we hear from youth is that it's not going to have an impact on mental health. Or, for example, this individual provided a post that said marijuana actually helped his mental health state. And when we look at the research, we see that there is certainly a relationship between cannabis use and certain mental illnesses, most prominently psychosis and schizophrenia. So, as I mentioned earlier, when an individual takes in cannabis, the THC that is in cannabis binds to the cannabinoid receptors in the brain, and these are responsible for a lot of functions, but also emotional regulation. And so we have seen that these receptors are also playing a role in the mental health of individuals, and this has been really well defined by looking at post-mortem examinations of individuals' brains who were living with mental illness, and we see an increased density of these receptors in those who have schizophrenia, and a decreased density of receptors in those who are living with depression. And so what we have been able to also see is that cannabis use is related to earlier onset of psychotic symptoms. It is a major risk factor for developing schizophrenia, and this is particularly true among those individuals who have a family history of mental illness. And so why this occurs may be related to certain variations in an individual's genetic makeup that may either be related to the cannabinoid receptors, or it may also be influencing their propensity to use cannabis. So I've just provided an example on the slide here of the COMT genotype. And this is an enzyme that's responsible for metabolizing dopamine in our synapses. And this is important because a lot of studies have found that the risk of developing schizophrenia is highest among those who possess the VAL allele homozygously, and who are also exposed to cannabis at a young age. So if you look at the graph, the leftmost bar shows that those who are homozygous for the VAL allele have the greatest risk of experiencing psychosis, and then this risk is much reduced if they're heterozygous or homozygous for the other allele. And so we know that this is also playing a role in people's response to cannabis. But the problem with this research is that it's very new, it's emerging. Some individuals have not been able to replicate this research. And it's most likely that there's multiple genes that individuals possess who are interacting. And so this is really an area of ongoing research at this time. The other concern that often comes up in this area is the question of what comes first. So is it that an individual is using cannabis and this is leading to the development of mental health disorders, or is it those who may already have developed a mental health disorder or be at risk for a mental health disorder are then more likely to be able to use cannabis? And so this is really something that's being debated in the literature at this time. We don't have a conclusive statement or position that we can take on this issue, but the one thing we do know is that there is a strong relationship and that risk is often increased in a dose-dependent manner. So the more an individual uses cannabis, the more likely they are to experience these harms. When we look at mood disorders, we see that the relationship is a little less clear. There's been a little bit less research done in this area. And so what we do know right now is that adolescents are having increasing rates of suicide, and we know that both drug abuse and depression can influence an individual's risk for suicide. And so we know that this is an area where we need to do a lot more research. And so cannabis use does lead to, or is related to, an increased risk of depression. And again, this is risk is increased related to how early an individual starts using cannabis and how frequently they use cannabis. And again, it's related to suicidal thoughts, especially among females. However, the research shows that it may be that a third factor is better able to explain the relationship between both of these variables. So, the research is currently supporting the notion that cannabis use is actually the precipitating factor behind the risk for depression, and that it's not flowing in the other way, but this is really new and it is still emerging. But what we know for sure is that cannabis use does lead to greater lengths of affective episodes as well as manic episodes, more rapid cycling among those who are bipolar, and overall increased disability and more severe prognosis. So regardless of the causation relationship, we still know that there's harmful effects coming from individuals who are using cannabis and who are living with a mood disorder. The story when it comes to anxiety is a little more complex because some studies have indeed shown that individuals with cannabis dependence have increased rates of distress and anxiety and panic attacks, which would certainly suggest that cannabis use may lead to the development of anxiety. But we also know that individuals who are living with social anxiety or experiencing post-traumatic stress disorder tend to use cannabis. And one longitudinal study of 3,200 youth who used cannabis before age 15-21 were more likely to report symptoms of anxiety disorders later in life, even after controlling for compounding effects. Yet, we have also seen studies that show that individuals seeking treatment for PTSD have reduced anxiety by up to 75% when they say that they're using cannabis. So it's very hard to delineate here exactly the impact cannabis has on anxiety disorders. There's clearly some differential effects that may be due to individual differences. And one possible route that this may be occurring is that cannabis does affect the hypothalamic pituitary adrenal axis, which is the system in our bodies that regulates our responses to stress. And the system is regulated by the endocannabinoid system. And so it may be that cannabis is somehow altering the effects of this system, which is then influencing how individuals are responding to stress. So we know that there is more research that needs to be done in this area as well. It really takes into account a variety of factors, which include an individual's biological makeup as well as some environmental factors that may be influencing them. Now we'll look at cognition. So we've heard from youth that they believe that weed helps you focus. And it says there's people who can do things even better when they're using marijuana than they may have been able to do if they weren't using marijuana at all. And in fact, what the research does show us is that early and regular cannabis use really can result in poor academic performance, and we've seen that youth who use cannabis regularly are less likely to complete high school or to obtain a university degree. And the interesting thing here is that a lot of imaging studies have started to being done, so brain scans of individuals who use cannabis. And the results are currently inconclusive. Some are showing that there's certain increases in the size of brain areas, and others are showing decreases in the sizes of brain areas. And so while it's not consistent, what's really important to know is the fact that there's changes happening, and neither is advantageous. So there are certainly impacts that are changing the actual structure and size of the brain. As these studies have shown that the earlier you started, the worse the effects were. And functional imaging has shown a lot as well. So this is when an individual is placed in a scanner and then asked to perform certain tasks. And then we can monitor how the brain is responding to completing these tasks. And what's often observed is increased activity in the brain, which may sound like a good thing, but is actually interpreted as the brain having to work harder to have to complete a task and needing to engage more resources to complete the task accurately. And so this may be related to the findings of structural changes in that the brain may have to compensate for the changes that are happening by having this greater activity. And the risk of this is that over time, the brain may become fatigued, and eventually it won't be able to compensate, and errors will start to appear in an individual's cognition. And this is when we'll see a lot of these changes in behaviors. And another finding that has been found in scanning is that those who demonstrate a reduction in brain volume may be able to start to show signs of apathy. And so I have to point out, of course, that these findings are simply correlations, and so it's unclear if, similar to mental health, if those who had changes in the brain structure are more likely to use cannabis use, or if indeed cannabis use led to these changes, or if it's a constellation of factors that may be coming together. A strong myth that we hear from youth very frequently is that they don't believe weed is addictive. They say that it's something you choose to use and you choose when to stop, and it doesn't present a risk at all for addiction. In fact, the evidence shows cannabis is addictive within the same range as that of alcohol. So 1 in 6 individuals who use cannabis during adolescence will develop a cannabis use disorder. And we define this as a problematic pattern of cannabis use that's leading to clinically significant impairment or distress, or their inability to complete the functions of their everyday life. And the last data we have is from 2012 that shows that 1 in 20 Canadian youth met the criteria for living with a cannabis use disorder. And so what this may look like in youth is a persistent desire to use cannabis, spending excessive time obtaining the drug or using the drug, using it even though they may be experiencing health problems, developing tolerance, so needing a greater amount of the drug in order to experience the same effects, and continuing use even though they may be experiencing negative social consequences. And indeed, withdrawal can occur among youth who stop using cannabis, and this can be experienced as irritability, anxiety, restlessness, changes in appetite, and sleeping as well. And so a lot of people compare cannabis to other substances, and what can be seen is that a disorder for cannabis can develop faster than that of alcohol or tobacco, and that it can take longer for some of the symptoms of withdrawal to develop. It's very difficult to make predictions about who will develop the disorder or assess how it may impact them, because cannabis is not a consistent substance. The concentrations of THC vary in different strains, as well as their methods of administration. So these are all things that need to be taken into account as we move forward. Some research does provide indicators of which youth may be most at risk for developing a cannabis use disorder, and the impact of these factors really depends on gender. So for males, we see that the genetic makeup is responsible for a little bit more than half of the risk. A shared environment is responsible for 20%, and the shared environment being that they may share with their other peers, such as parents, or going to common activities, and an unshared environment is responsible for almost a third of the variance. Unshared environments being things such as a different social circle or a different life experience they may have from the rest of the population. And when we look at females, we see that the genetic variance is a little higher, it's 59%. The shared environment is responsible for 15%, and the unshared variable is responsible for 26% of the variance of their risk. And when we speak about genes, it could be related to multiple factors. Genes may be something as simple as just contributing to how well an individual responds to their very first experience with cannabis. And so why some people have a good experience their first time with cannabis and others experience anxiety. But the exact genes and the pathways through which these things are occurring are things that still need to be further explored. Other risk factors for cannabis depend use before the age of 15, a low socioeconomic status, individuals who use other drugs, who use regularly, those who demonstrate antisocial behavior, those who use tobacco very frequently, youth who may be living alone, youth who use cannabis to cope, and the number and type of recent life events that have occurred to the individual. And the only protective factor that has been found at this point is religiosity. So we did hear from some youth acknowledgement that cannabis use can be problematic. And so one youth has said that I realized I had a problem when I woke up in the morning, and the first thing I say is I need some herb in my system. Multiple efforts have been made to try and prevent cannabis use, especially harmful cannabis use. And so school-based prevention programs have been shown to have a moderate success rate at reducing adolescent cannabis use. And these were most successful when they incorporated elements from multiple prevention models that were longer in term, so 1 year or longer, that was facilitated not by teachers, and that targeted high school students as opposed to those that looked at middle school students. And there hasn't been enough research yet to really speak conclusively about the efficacy of programs that are not delivered in the school system. One of the factors that we cite in our report is that individuals working in healthcare may be very well placed to screen individuals, and particularly youth, for problematic use of cannabis. And so we suggested that it would be great if all youth, regardless of risk factors or not, were screened for cannabis. And so some of the screening tools that we have acknowledged is the CRAS, which addresses various factors or variables along which a youth may be using cannabis. So do you ever use it when you're in the car, whether you're driving or someone else is driving? Do you use it to relax? Do you use it when you're alone? Do you ever forget the things that you've done while using? Do your friends or family say that you should cut down? Have you ever gotten into trouble? And there's also the brief screener that addresses tobacco, alcohol, and other drugs, which is really well suited to use. And there's been a number of other interventions that have been developed specifically for youth. Project Chat incorporates motivational interviewing to determine how well a youth may be motivated to change and to help make a plan. And the checkup is also a 2-session intervention that uses motivational interviewing. And brief interventions such as these have been shown to show some initial success in reducing cannabis use. But we also state that it's important to know when an individual should be referred to treatment if they're experiencing very significant impairments, such as interfering with their academic, occupational, family, or social goals. And I know that RNAO has developed some great resources to help nurses, and so we'll discuss those as well at the end of the presentation. Looking at the efficacy of behavioral interventions, there have been a lot of studies that have focused on different types of psychosocial therapies, such as cognitive behavioral therapy, motivational enhancement therapy, and multidimensional family therapy. And what trials have shown is that all of these therapies are effective in reducing cannabis use among youth, and no one particular style has had superior effects over the other. The other area that's being explored is contingency management, so rewarding individuals when they abstain from cannabis use. And it hasn't on its own shown that it is able to increase the urine-free samples that are, cannabis-free urine samples that are obtained from youth, but it's not yet clear if this may be able to enhance some of the other interventions that have already been discussed. But overall, these have been able to show a reduction of cannabis use by up to 34% of the sample abstaining at the end of treatment in comparison to only 4% abstaining at initiation. Emerging research is also looking into pharmacological interventions, and these may focus on things such as reducing withdrawal symptoms, helping people abstain from using cannabis, preventing relapse, and as well as treating other co-occurring disorders that may be occurring. And this is a really new area, though there have been some positive laboratory findings. They haven't yet been able to observe any improved clinical outcomes in trials, and of those trials that have occurred, adolescents were not the target population. So we can't say conclusively that it may work for youth, but those that are showing promise show that medication can diminish withdrawal symptoms and reduce craving. A new area of treatment that is really starting to become a hot topic and that makes a lot of sense, especially when dealing with youth, is the idea of web or computer-based interventions. And so these are things such as apps that a youth may access on their phone or a website that a youth can go to. And the idea behind these is that they're really easily accessed. They're accessible because you could just be on your phone and nobody would know what you're doing or be aware that you're receiving treatment, which avoids the whole notion of stigma. And it can also be right there for youth in high-use risk situations. So they may be at a party and all of a sudden cannabis is being passed around and they can turn to their app for support, whereas with conventional treatments, they might not be able to call the individual who's helping them in that moment. So this is an area where we're really seeing a lot of movement and where a lot of evaluation research needs to take place. So in conclusion, the key messages that we really want you to take away from this report is that it's important to talk to youth about what's a myth related to cannabis and where there's concrete evidence. Encourage them to delay initiation of use so that they can protect their brains. Let them know that regular use can indeed influence their driving, their cognition, and their mental health, and that it can also be addictive. If you have the opportunity in practice, we encourage you to screen youth for problematic use and to know the appropriate treatment and referral options. So the Registered Nurses Association, this is my contact information. If you have any other questions, if you have ideas for how you'd like to use this information, please do not hesitate to contact me. I'd be glad to hear any of your thoughts. Oh, and so I'll ask Dr. Cerrone now if she would like to speak about her findings in practice working with youth and the implications of cannabis use.
Thank you so much, Sheena. Dr. Cerrone, before you come in, thank you, Sheena, for presenting a very excellent overview of this evidence-based report. We think it's a very useful tool in terms of using it as a report to inform policies and programs. And we're happy now to have Dr. Cerrone to present a practice-based perspective. Dr. Cerrone, are you on the line? Can you unmute your line, please?
I'm here. Can you hear me?
We sure can. Can we get confirmation from the participants that they can hear Sharon on the line? Thank you very much. So we have a couple of questions for you, but perhaps, was there something that you'd like to reflect from your perspective in terms of your clinical practice and in terms of adolescent addiction that you want to reflect on from your perspective as a practitioner?
Well, I want to reflect on the document that Sheen is referring to from the CCSA. I hope everybody has access to that online. So keep in mind that this was a collaborative process, multidisciplinary consultation around research, whatever hard data we have around youth using cannabis. So keep in mind that a lot of it does focus on the negative issues or the impacts that are harmful to youth, and that's important for us to understand. However, when youth walk into our office, they're often highly endorsing of marijuana for a variety of different reasons. And so what we tend to hear in our practices is a lot of positive feedback about marijuana from our patients, not just youth, but a lot of adults who now are in the situation where they can seek a prescription for marijuana. So under those circumstances, you're going to hear a lot of positive endorsement. Doc, it's okay for me to smoke pot. It's natural. You know, Doc, I feel a lot better when I smoke it. Doc, it helps me with pain, those kinds of things. So, so keep that in mind in the balance of the document. It's a very, very, very helpful document. I'm not saying that, I'm not falling on the side of cannabis either being good or bad, right or wrong. It's just helpful to know the facts. And then we take the facts and we navigate these extremely challenging conversations with our patients. So that's my first reflection, but if you want, I can answer the questions if you like. Can you still hear me?
It's Tamar. Can you hear us, Sharon?
I can now hear you. Yeah, did you hear what I said?
Yes, we heard it clearly. We were just on mute over here. So thank you so much for those reflections. And again, the report is available in the file share pod and on the CCSA website. So Dr. Cerrone, from your perspective, what are some key emerging trends that you see in your daily practice with respect to cannabis in adolescents?
I don't know that there's any emerging trends in their use. It's pretty much the same as it has been for a long time. It's the second most commonly used substance after alcohol, and that's been for a long time. It goes up and it goes down in certain eras for a lot of policy issues, availability issues, social endorsement or not. And so we saw some of those trends from the OSDA study at the beginning of the talk. So I don't know that their use has changed a whole lot. Their justification for the use, it will increase because there's a lot more societal permission and endorsement of marijuana use. What the new trend, of course, is that in April of 2014, physicians and nurse practitioners in some provinces have been granted or have had imposed upon them the federal legislation to prescribe marijuana. That's the new trend. And that causes a lot more confounding conversations for us, especially with youth.
So from your clinical perspective, what would you say are some key screening and intervention techniques that work specifically with a young audience?
Any screening techniques are dependent upon having the youth in our office in the first place, and let's all keep in mind that in an individual clinical setting, not a lot of youth come in. Perhaps in youth-specific services, we have a lot more interface with youth in schools and in social agencies, and that's where we get larger numbers. So first of all, they have to be walking in the door. So we have to create youth-friendly, youth-accessible environments. Number two, all of that implies rapport development. The emphasis for me is always on rapport, no matter if this is a parent's agenda, a parole officer's agenda, or probation officer's agenda, a teacher's agenda, or the kid's agenda. Everything hinges on rapport development. They're not going to come back a second time if I don't work on rapport, and screening is not that relevant if I can't have them come back a second time or be able to refer them to an agency or a person that might be helpful to them. When and if all of those are satisfied, then the screening tools I use is the CRAFT questionnaire. I don't know if it's posted. It's referenced in the document that Sheena talked about, and it's easily accessible online. That's an acronym for CRAFFT, and it's an accessible product online. It's 5 questions that you ask. If 2 or more are positive, it's an indication that we should be asking more questions and considering next steps of interventions and referral to treatment.
And I think what I'm really hearing from you is really we need to take a really intersectoral approach to thinking about this issue and really taking an upstream approach to this.
Yeah, I wish I was as well spoken as you. I'm not quite.
Oh my gosh!
I say yes to what you're saying. I'm not quite sure what that means out in the field. But we all have to share responsibilities. Like this is through the education sector, through the social services sector, the healthcare sector, and in collaboration with parents and other guardians. Yeah, it all hinges giving the right information, the accurate information to our patients, our youth. and being able to engage with them when they have questions or when they have problems with these substances is important.
What would you say are some of the key messages that you use that are successful in terms of translating this issue to young audiences?
I think the key message is I'm listening. I hear what you say. I'm listening. Let's hear the pros and cons of why you're using this substance, why you think it's helpful to you. And just because someone tells you, I feel more comfortable, I feel less anxious, I have less pain, does not necessarily mean that it's a right medication to prescribe. There's a lot of patients who will tell me the same thing for Valium, and I'm not writing a lot of Valium prescriptions either. So this is the new kid in the block, on the block in terms of what we're able to prescribe. It still requires very rational prescribing and very thoughtful decision-making in our prescribing and in other interventions that we're using. So that is highly reliant on the therapeutic alliance with the kid that we're working with and on the ability to see them again and have a conversation over time.
Thank you so much, Dr. Jerome. We have a couple of questions from the audience, and actually, if you wouldn't mind staying on the line, and Sheena, unmuting your line, and I'll turn it over to Sabrina Morali, who's with the Registered Nurses Association, to maybe highlight a couple of questions. I realize we're a little over time, but maybe we could just leave room for a couple of questions.
Sure, thank you. There is a question about adolescent marijuana use and the use of marijuana to help with chronic pain. Are there any comments on that, or are there any sources of literature or information that are available that we could refer users towards?
So that's a huge Pandora's box, right? Chronic pain is a very complex area of care, and then in children and youth, it's even much more complex. To the best of my knowledge, the team at Sick Kids does an amazing job, and they have a lot of online resources. There is no simple answer to this. It's very complex, and I think it requires a multidisciplinary approach. And you can't respond to that in one single visit with a kid. So bring in others to have discussions around this, and just because someone says it helps me with my pain does not mean that you put pen to paper and start prescribing. You have to weigh the pros and the cons, just like any other medication. Let's learn from what happened in the opioid prescribing crisis, and let's do this thoughtfully. That being said, sometimes it can be a helpful intervention.
Perfect, thank you. There are a couple of questions with regards to prevention programs. Can you comment on any individual prevention programs for youth, as well as any policy interventions that might be led through, for example, public health units or local community organizations?
Is that a question for me?
Either you or Sheena.
So I'm just going to say before Sheena, I'm just going to say I am a mere physician working out of my practices in social service agencies in Toronto and Northwestern Ontario. In remote First Nations communities. So you know, it's not the domain of physicians to be involved in prevention programs. We need to support the programs that are happening in the media and that are happening in the schools. And I think there's probably way more nurses in the front line that may be involved in the opportunities to have prevention messages. Than I would be. And I think some of the messages that come in the document that Sheena reviewed are very relevant in prevention programs. How you present it to youth is complicated. They don't like the commercials that we like necessarily.
Perfect. Yeah, and I'll just add to that. Somebody commented on the Cycles program that's being conducted by Barb Moffat and Joy Johnson in BC. So that is something we have had a very good relationship with them. They have developed basically a movie that shows the story of how a youth may choose to begin using cannabis, but it incorporates questions throughout the movie, and they've developed guides for educators to stop and have conversations with their class while they're watching this movie, and just to take some time to reflect on how they would react in the same situation, what the implications of that behavior may be. I don't currently know if that has been evaluated, Similarly, I spoke about the Eggs on Weed campaign, which I referenced during the impaired driving slide. That was developed by the Ontario Students Against Impaired Driving. They have a website. If you Google Eggs on Weed, you should be able to find it. But again, I don't know of any current evaluation data that proves its efficacy.
Perfect, thank you. There's a couple of questions on an interesting topic about legalization, especially with the upcoming federal election. We anticipated to hear more about legalization of marijuana from the federal election, and obviously have not. It hasn't been a hot topic. But can you comment about how we could foresee regulation of cannabis in terms of level of use amongst youth, or can you comment a little bit more about legalization of marijuana, and are we there yet with terms to the literature?
Is that okay if I speak to this, Sheena?
Sure.
Okay. So I'm going to respond just as a Canadian citizen. So for the first time last night on the news, on the televised news, I saw the leaders of the different parties commenting on marijuana for the first time in this election campaign. And it's a surprising number of Canadians that are interested in either legalization or decriminalization. All of that in mind, I think we have to respect that the brain is growing until at least the mid-20s. That's the evidence we have thus far. And that we have to respect what we introduce to the brain and what very important neurodevelopmental stages may be affected or halted or deferred by any chemicals, cannabis or otherwise. And so I would imagine that under whatever legislation passes, and I hope that each and every Canadian gets to vote on this, that we take something into consideration of how to provide caution for young brains. What's going to happen? That's anybody's guess, right?
Thank you, Dr. Cerrone. You couldn't have said that.
I'll just add in that TCSA has a number of policy papers on our website that speak to the impact of decriminalization as well as legalization of marijuana and considerations for the impact these policies could have on youth and other considerations for society.
Perfect, and thank you both for your very informative question. I have one more thing to add. It's interesting again about the federal election and the issues that are coming up this federal election. I really highly encourage you, if you want more information on health-related information and the federal election, RNAO has some wonderful resources online. You just have to go to rnao.ca and look for Why Health Matters. It's right the first on the top of the screen, and it's an entire pamphlet dedicated to health issues and how the response of the 3 or 4 leaders have been responding to them. And we've also put out question platforms on healthcare issues to the leaders. And I've had 2 responses from the NDP and the Green Party. The answers are online for that as well. And on that note, I will wrap up our question period for now, seeing that it's 12:05. And I'll turn it over to Kyle to conclude our webinar.
So thank you so much, everybody, for joining. Our time is now up, and thanks to those of you who stayed on a little bit longer. There was great interest from the audience, so thank you for your great questions. You will be receiving very shortly an email from the Registered Nurses Association of Ontario, specifically me, that will include a link for a short evaluation survey. You should be receiving that tomorrow. We're just waiting on our IT team to upload the certificate. That will be linked directly after you submit the evaluation. So we appreciate your responses, and we're always trying to look to better these webinars. And we do always have more webinars and knowledge exchange sessions happening. So if you can visit us online, www.rnao.ca/mental health. I will be leaving up the file transfer pod just a few moments longer after we end, just so that you can download any of those resources. And once again, thank you, Sheena and Dr. Sharon Cerrone, for presenting today. We greatly appreciate it. Thanks so much, everybody. Have a great day.